We'll go to the next talk, the tumescent anesthesia. Again, very brief. There's only one reference and one data point that you need to remember from this talk. Everything else, which is not much, is very, very quick. Okay. So tumescent lidocaine anesthesia was developed by Jeff Klein. There had been some kind of uses of this previously, similar to lasers. Lasers were being used before Rock Sanderson and John Parrish kind of revealed why they work. But Jeff Klein revealed why it works and how you can do it on a large scale safely. And that is, you use very dilute lidocaine with epinephrine. It seals off all the vasculature of the fat and maintains the fluid in there, which gives profound anesthesia. I do a lot of liposuction. You can, before 1987 would 100% require general anesthesia. About half my patients drive themselves home after liposuction. So it's phenomenal. The word tumescent is appropriate for phlebectomy because you are tumescing the fat. These are subcutaneous veins. But it is definitely a misnomer for endovenous ablation, where you are injecting within a fascial plane where that fluid gets absorbed much more quickly. And how we determined the 7 milligrams per kilogram that I'm sure everyone has heard of before for lidocaine was based off the FDA just saying, well, this is what procainamide does. You know, they say 7 milligrams per kilogram, so we'll just give it the same number for lidocaine, which is really nonsensical because just for straight 1% lido with epi, it's probably much higher than 7 milligrams per kilogram. But I have done about 5 milligrams per kilogram of lido without epi, and the person became extremely, toxic. They didn't know where they were within a few minutes. So if that were to happen, this is a good teaching point. If you think the person making your bag forgot to put epi, all you do is just take a bag, put 1 or 2 milligrams of epi and just start pumping it in there as fast as possible. Within a couple minutes, the patient's back to normal. They won't need to be hospitalized. You don't do that, and you better get an ambulance as fast as possible and get them to an emergency room. So it's very easy to avoid problems. And if you ever suspect that's happened, just start pumping fluid with epi, and it really stops the outflow of that lidocaine to the bloodstream almost immediately. And that person was fine. They didn't know where they were. And then within 5-10 minutes, they felt nearly back to normal. Usually they'll have like this almost kind of weird feeling, almost like viral symptoms for the rest of the day. So this was the original kind of mixture for tumescent lidocaine. It's still the one we use today. It's normal saline. You can also use lactated ringers, but normal saline is the standard. We use 1% lidocaine hydrochloride, the goal being that you get some final concentration in a liter bag of 0.05 to 0.1. For vein procedures, I always use 0.05. There's no need to use 0.1%. And you add like 1 milligram of 1 to 1,000 epi, and you add some bicarb to just help with the burning pain. If you're using lactated ringers, you may not need bicarb, or probably less bicarb. I use spinal needles. I use an infiltration pump to kind of get it in. You can use syringes, but these are not very expensive, a few $100s. And so the goal is that we are injecting around the vein. So you can see the vein with the laser fiber highlighted in the center there. And so you get less pain. You can do this away. It provides a heat sink, so it absorbs most of the heat. If you were to do an ablation without proper tumescent, the skin and soft tissue would just start to die off on top of it. And there was a case that Bob Weiss, there's a photo I have somewhere, where someone came in and all the skin above where the ablation was performed was necrotic. And so this makes it so much easier. It can be done awake, and people very commonly drive themselves home with no issues. And it can also compress any tributaries that are in that area. And so it makes it a lot less likely to get recurrence because of those. The key exam reference is that according to this article from yesterday, 1990, the maximum dose of lidocaine dosage is 35 milligrams per kilogram. That is not really what we know now, but that is what they may ask, because the references have not changed since we took our exam in 2015. So I would expect they're using a similar set of questions nowadays. The maximum dosage now that we know is actually between 45 and 55 milligrams per kilogram. And that is not, and that's all based on liposuction. So, and that is not related to what happens if you inject and do liposuction. That is based off of what happens if you infiltrate an area and cannot do liposuction because of an emergency. They were all completely filled with fluid and they have a seizure and you have to call it off. At 45 milligrams per kilogram, the risk of them having toxic levels of lidocaine in their blood is probably 1 in 10. That does not mean they would be symptomatic because that increase is very slow. So as far as symptoms go, it is not based on how high levels in their bloodstream, but also how fast that level builds up. So if it builds up very slowly and it's over 6 micrograms per mil, they may not have any symptoms. But if it builds up over 10 minutes, their body can't handle that rapid rise in lidocaine, and the symptoms will start almost immediately. When not performing liposuction but infiltrating fat, it's 20 milligrams per kilogram. Because again, at that point, it's probably like 1 in 10, 1 in 100 risk of developing registerable toxic levels in the blood. With endovenous procedures, I would caution you to go over 10 milligrams per kilogram, although I doubt you would ever reach that much unless they're as like skin and bones and you're treating both, or multiple veins at the same time. That potentially could be reached. But I say less is more with that, just because we're not really sure how fast it's absorbed into the bloodstream. And no one's really done any large-scale study of getting blood draws with different amounts of tumescent anesthesia inside a fascial plane, although I think that would be very useful. So greater than 6, this is actually, it should be micrograms per mil, is considered toxic. But people even below that can get lightheadedness and drowsiness. It becomes an issue once they reach above 8, where they can actually end up dying. And there have been multiple reports of people using tumescent anesthesia improperly, including one told to me by a plastic surgeon where an MA had decided, I've seen enough liposuctions, I'm going to do liposuction on my friend. And so a medical assistant brought in her friend, started injecting her with lido with epi, and the person died on the table from, toxic levels of lidocaine. So done properly, unbelievably safe, and unbelievably low risk of adverse events. There are some kind of fun studies that I've seen over the years. Room temperature fluid tends to give higher pain scores. So cold fluid does better. And not only that, but it also gave less bruising, less induration, less risk of paresthesia. And that is something that could be done for infiltration before thermal ablation, but I would never do this with lipo. With lipo, we're using warm fluid above room temperature. Otherwise, with cold fluid, you could end up killing them from, hyperthermic events. So, but for this, you're, again, not putting a lot of fluid in. It's something to at least consider or keep in the back of your mind. But not only that, they also found that the lasers perform better at colder temperatures. So reduce the risk of perforation independent of wavelength, and the performance and potentially the closure rates, these were in vitro studies, could be better in a colder medium than a room temperature medium. And so you get this diffusion of perivenous TLA where in this study, they looked at infiltration before ablation or infiltration before and during, and the pain scores were better if you continuously infiltrated during the ablation. I think it also comes down to technique and how far of a segment you're doing. If you're going from above the medial malleolus all the way to the groin, you may need to re-infiltrate somewhat before you reach all the way down to the bottom. And it depends on the person and many variables, I'm sure. Tumescent technique for ambulatory phlebectomy, is ideal in that now you can do phlebectomies completely awake, reduces the risk of bleeding. I've never had a hematoma from ambulatory phlebectomy, and bruising is variable. Some people just bruise a lot more than others, but very, very safe. And so what they found here is that there was no need for IV sedation, mild perioperative and postoperative pain, complete tumescence. Complete tumescence is not the goal either with this or with liposuction. It is complete blanching of the area. That is the goal. The tumescence will go away over time, but the blanching in the fat can last hours, sometimes even 6 or 8 hours before it starts wearing off. It also hydrodissects the fat. So theoretically, it may be helping with extrusion of that vein, but I don't know for sure. Laughing gas. I have used this a couple times, and I would say use this cautiously because some people will, like as Vineet was telling me yesterday, one of his patients exhausted a tank in one session, not for ablation, for some other laser procedures, but some people will use it really aggressively. And so you can use laughing gas like Pronox, where they just breathe it calmly. And some people will start holding their breath longer and longer, and it makes it a lot more effective. But the last time I used this, the patient was using it, and at one point, the laser fiber was in, went like this, and nearly threw the laser fiber outside of her leg. Luckily, I like grabbed her leg and held it down so that it was maintained, because the laser fiber was I'd already tumesced around it. At that point, if it had come out, I probably would not have been able to get it back in. And so if you're going to use something like laughing gas, make sure they use it sparingly and just enough to minimize anxiety, not so that they don't know where they are anymore, because that is definitely possible with laughing gas. I've had people think they were getting a violin lesson during some laser therapy. So, you can really mess with their mind. That's it for me.